Okay. Maternal assessment or antepartal assessment. I tend to kind of stay here when I've got to do this because this doesn't really hook on. I'm afraid I'm going to drop it on the floor. So if I'm not pacing around, which drives me crazy because I really do like to walk around the room, I'm just kind of stuck here with this thing. Maternal assessment, what does that mean? What is that? Right. It's your head-to-toe assessment, which you're going to be documenting in clinical. It kind of bills. And then you're going to add the female stuff or the pregnancy stuff to that. Talking about the uterus, the fundus, the breasts, the vagina, all that stuff. Okay? So we're going to talk about some aspects of pregnancy. The diagnosis of pregnancy and how we diagnose it. So we have different signs that categorize the pregnancy. The first ones are presumptive signs. And these are signs that are not written in stone saying that this is definitely a pregnancy, but it could be. The first one, amenorrhea. The patient has missed her period. But can that be related to anything else? Yes. It can be hormonal. You can have a very athletic person that doesn't have a whole lot of body fat that would have their cycles all mixed up. And they may not get a cycle 1 month and they may get one the next month. So again, it's just something that could be, but not definite. Nausea and vomiting. When we talk about pregnancy, it's related to a hormone. And it gives them like morning sickness. But they could also get it at all times of the day. It doesn't necessarily mean it's just in the morning. But it could also be something that's related to a virus, upset stomach, maybe a flu, maybe they ate something that didn't agree with them. So again, it's not something set in stone. Excessive fatigue. They get very, very tired. Very, very tired when you're pregnant. But you can also be very, very tired. I'm sure you can be very, very tired this week, right? So it doesn't really mean it's related to pregnancy, but it could be. Urinary frequency. Well, as the uterus grows with the baby inside, the fetus gets heavier and heavier. It weighs down the bladder. So they get a lot of frequent urination. But again, what else could this be related to that doesn't have anything to do with the pregnancy? A UTI. Breast changes, there's a lot of changes going on with the hormones in the body, but you can also have hormonal changes when you're not pregnant. Breast changes. Usually before people get their cycle, their breasts get very, very hard, they get engorged, they get sore. So it can be a lot of changes. Quickening is something that is a presumptive sign, but really doesn't happen till, like, if you would be pregnant, like the 15th or 16th week. And that's the fluttering. Baby feels like it's fluttering, but it could also be gas pain. I had a lady that showed up at the ER, and she was pregnant, and she was really pregnant, and she was still in denial. She said, it's just bad gas. I said, no, it's not. That's some bad gas, if it is, because that's some serious stuff. But it's feeling that baby fluttering. It's almost like a little fluttering feeling. It's called quickening. The next signs, probable signs, these are usually signs that are seen or discovered by the practitioner, the doctor, the nurse practitioner, the nurse even might find things. Abdominal enlargement. Usually the abdomen does get enlarged, and that is a normal sign with pregnancy. It does grow, but it can be related to something else like fibroids, or she could have some just bloating, something else going on. Goodell sign and Chadwick sign kind of go hand in hand. This is my slide that it shows a great view of Chadwick sign, which is this bluish hue here. My only thing is that there's no glove. So you would wear a glove. I don't know where that came from. But anyway, the bluish hue is Chadwick's sign. And what it is, there's so much changes. The hormones change, causing increase in vascularization to those areas. And when they do, that surge of volume of blood goes to those areas, and that's why you get this bluish color of the cervix. It also gets soft. It softens with pregnancy. So the practitioner will do an exam and feel a softening of the cervix, which is usually very firm, but it'll soften almost to the consistency of an earlobe. And that's how they describe it. I mean, I always feel them, but they're way past that. I mean, we're big and pregnant by then, so I don't know what it's like at the beginning. But it also is very flexible, and that's that Goodell sign, that uterine neck and that area. Another thing is called Hager's sign, and that's the lower uterine segment that gets very, very pliable. It gets very, very flexible. Probable signs, again, pregnancy test that's positive. Well, it's not written in stone still, but it's very possible that it could be pregnancy. But do you have false pregnancy tests? False positives? Yep. Braxton Hicks, that's a tightening and relaxing of the uterus. Usually it's very painless, just more irritable than anything, because it's kind of a tightening of the abdomen and relaxing. And usually these are, I call them practice contractions. They really don't hurt, but they're more annoying than anything. The big thing with that, we'll have patients call in and say, hey, I think I'm in labor. And I'll say, let's see if you have Braxton Hicks. Why don't you walk around the block a couple of times and call me? And if the contractions continue, then you're probably in labor. If they stop, any kind of exercise or anything with Braxton Hicks, usually they dissipate. Ballottement. Ballottement is, think of a balloon bouncing up and down very slowly. Ballottement is usually around 16 weeks, where the practitioner will feel a bouncing or a fullness feeling bouncing off their gloved fingertip. And it's usually that cervix is just, it becomes, the baby is ballottable, where you can feel the cervix. You're not feeling the baby, but the cervix. And it's kind of that ballottement. It bounces up and down. Think of a balloon. Positive signs, these are signs that can just be attributed to pregnancy. It can't be anything else. Fetal visualization. Well, a vaginal ultrasound is one way that we can see it, right? We can also see it with a transabdominal. The vaginal probe, though, is what they will use at the beginning of the pregnancy. And some of you I know that have had ovarian cyst or any kind of pelvic anything going on, if they want to view that area of the abdomen, they may do a vaginal ultrasound. And that's how we look at the fetus, especially very, very early. I'm talking about 5 weeks even. You can see 5 weeks, the baby's heart's beating. You can see it with a vaginal ultrasound. You can't see that with a transabdominal. The baby has to be like 18, not even maybe 17 weeks, 18 weeks gestation before you'll see anything with the transabdominal. That's the one you're probably more used to seeing that passes over the abdomen with a monitor. So ultrasound is one way. You can see it with an x-ray, but it's not recommended. It's very much contraindicated. I have no uterus. I have a total abdominal hysterectomy a long time ago, and they still ask me, is there any chance I could be pregnant? I said, I just wrote that on my history. That's okay, Ms. Herrera, but I just need you to sign this paper saying that you're not pregnant and that, it's okay to do these x-rays. So even more so, it's so important. It can really cause some problems. Can cause some anomalies, fetal abnormalities. So they recommend no x-rays. Fetal heart sounds. Well, that's pretty positive. When you can hear the baby's heart rate, right? Well, we can hear it again. The big monitor usually around 19, maybe 16 to 19 weeks, somewhere in between. And you can't keep the baby on the monitor at that point because it's so little it moves everywhere. But we can do a Doppler. A Doppler, just like you would find your cardiac patients' pulses and things such as that, you can find the fetal heart rate. It's usually very low into that suprapubic area because we can start doing this like, very early in the pregnancy. Usually you can hear it at 10 weeks gestation. So from 10 weeks gestation on, they're looking for that baby's heart rate in the office when you go for your visit. Uterine souffle and phonic souffle, it's just the way we describe the fetal heart tones or the fetal heart rate. A uterine souffle could be, we could be passing that Doppler over that umbilical artery, and then you're going to hear that brewy sound. It's very slow. That's maternal. That's mama. The other one is it's almost like a crispy beat. It's just a hard beat. It's very fast paced. It almost sounds like a little galloping horse. It's very fast. And it doesn't sound like a brewy. It doesn't sound like it's like far off somewhere. It's very distinct. It's very, very, very fast. And we call that phonic. Fetus, phonic, that's the fetus. Palpable fetal movement. Mom can feel that baby move around. You can feel it move, usually depending on your pregnancy. If you've been pregnant before, you kind of know what you're feeling, so you recognize it earlier. It's not that it happens abnormally with more than one pregnancy, but you're more in tune to what you're feeling, whereas first time you don't know what you're feeling, and then by the time you discover it, it might have been happening for 2 weeks. So it's usually 18, 17 weeks, around that time, that you'll start feeling movement. Okay, I got to take this with me because I got to go over there by the board. We're going to talk about how to take a history. When we describe the pregnant woman, of course, it's not all just things that we're measuring and looking at, but we're also asking her questions about her pregnancies, her pregnancy history. What was the outcome? How many pregnancies did you have? So when you see gravida or G, that stands for how many times the patient's pregnant. Okay, so this example here was from the last class. Miss Jones walks up. She's got pregnancy number 2 here. She's got a set of twins that were delivered at 38 weeks, and she's pregnant again. Well, just to kind of give you some little background information about how to figure this out. Gravida is the number of pregnancies. Parity is the outcome past 20 weeks gestation. A pregnancy is divided into 3 trimesters. Weeks 1 to 13, 13 to 26, and 26 to like 41, 42. Anything past that is considered post dates. Okay, but it's broken up into 3 segments. When you're pregnant, we consider the baby viable, like if the baby was born early and this baby had any chances to survive outside the uterus, that's viability. We consider viability after 20 weeks. So if mom is pregnant and she loses this pregnancy prior to 20 weeks, we consider that an abortion. Now, an abortion doesn't mean to go out to the clinic. That's elective abortion. A spontaneous abortion is when she loses the baby spontaneously on her own. Her body throws it off for some reason. So that is considered prior to 20 weeks. If she loses a baby after 20 weeks, she comes in clinic and says, I'm 24 weeks pregnant and I haven't felt my baby move around. So if the baby dies in utero, it's called a stillborn after 20 weeks. A miscarriage prior to 20 weeks, a stillborn after 20 weeks. Preterm is 20 weeks all the way to the beginning of the 38th week, the end of the 37th week gestation. You have to know what preterm is to figure out this, because you have to decide whether this is a preemie or a term delivery, or if she lost the baby prior to 20 weeks, was it an abortion? Yes. 20 weeks, all the way to the end of the 37th, beginning of 38th. Another little tricky thing is when they're pregnant, it's one pregnancy. Whether there's 8 octo pregnancy things going on, whatever. Okay, it's one pregnancy. It's also one event or one delivery. Okay, and that's why I'm telling you the P, you only get credit for a P if it makes it 20 weeks or beyond. So, say Miss Jones had a miscarriage with her first baby, and she carried that baby to 12 weeks, okay? But she lost that baby. She's currently pregnant with her second baby. So this is how many times she's pregnant, no matter if she's pregnant for 1 week, 2 weeks, 10 weeks, whatever. She's pregnant now. She's given us her history. She had a miscarriage at 12 weeks. So she's a gravida 2. This is how many times you're pregnant. This is the outcome of the delivery past 20 weeks. Did she deliver a baby past 20 weeks? No. So she's a 0. But the parity is like an umbrella. And these are the terms under the umbrella that specifically tell us what happened. So like term, preterm, abortion, and living. T-PAL is under the P, which is the umbrella term, parity. So what would be her T-PAL based on this? We don't know anything from this, right? So term, 0, right? Preterm, did she have preterm? It was 12 weeks, right? So we know that that's not preterm. It has to be 20 weeks to end of 37th week, beginning of 38th. Abortion, 1, and no living, right? Okay. Now, scratch that all from Miss Jones' history, okay? This is another patient. Say this is, I don't know. This is Miss Tolliver. She comes in, and she's pregnant for the second time, too. She has a set of twins at home that were delivered at 34 weeks gestation. So were they premature? Right. So she's a gravida 2. She's currently pregnant, and she's got a set of twins. That was her outcome. Was it past 20 weeks? So we can write something up here. But it's twins, but just because it's twins, it's one birth. Now, they were preemie, so this is what I have. 0 term, 1 birth, that was preterm because they were 34 weeks. No abortions or miscarriages, and that's where I'm putting my twins. That's the only place you're going to have more than 1 baby. So do you see why this is how we like to take a history on our patients? Because it gives us so much more information than just saying G2P1. That really doesn't tell me anything. Would you know that there's a set of twins here somewhere? No, but this is where you'll see it. Okay, so you'll be figuring that out, and you'll be answering that for the test for sure. You'll see it again. So you want to make sure on Canvas, I did post an exercise that goes through how to figure these out. They're practice questions, and they have answers. I also have one on here for you. Jane is currently pregnant at 10 weeks. She has a set of twins that were delivered at 34 weeks gestation. She had a miscarriage at 6 weeks and had 1 other delivery at 39 weeks gestation. These are kind of what the questions will look like. How would you record the pregnancy history using the GP and T-PAL method? What did y'all get? How many pregnancies? G4. Parities, past 20 weeks. 2. Very good. And her T-PAL. She had that term baby at 39 weeks, right? And what else? She had an abortion, and she had that 1 preemie delivery of twins. Even though it's 2, she's 34 weeks. So it should be 1, 1, 1. And how many living? 3. Very good. You set of twins and you term baby at 39 weeks. Don't forget, the big thing people forget is that the first sentence, Jane is currently pregnant. So if you didn't get G4 and you got a G3, that's why. You forgot she was currently pregnant, right? So you'll work those exercises and practice, okay, because you will see it again. I definitely know that you will see it again. Okay, so here's the explanation for that. Moving along, physiologic adaptations. There's a lot of changes that go on with the body. First of all, the uterus will change. It grows with the baby. Remember, the uterus houses the baby for all those weeks. It is the baby's house. So it will grow as big as the baby. It usually starts out the size of a grapefruit, and then it grows with the pregnancy. So it increases in length, it increases in weight, and it increases in blood volume. In fact, there's like 1,000 milliliters extra of blood volume added to that muscle, which is the uterus. Why do we have all that vascularization going on? To get that perfusion to the baby, right? Through the placenta, the umbilical cord, all of that. We have a thing called supine hypotensive syndrome. Well, as the baby grows, the uterus also grows, and it gets heavier because there's all this extra volume going on. So as it grows, it tends to compress the vena cava if the woman lays on her back. So a big no-no. Never, never, never let a pregnant woman lay flat on her back because she's going to have supine hypotensive syndrome. When that happens, hypotensive syndrome, what happens to the blood pressure? It drops. Do you think that oxygen and that perfusion gets to the baby? No, it doesn't. So at some point, this baby's going to have some problems with distress. It's almost like cutting off the oxygen. So we never want to leave them on their back. Even if you slightly tilt them off their back with a little like blanket or something. A lot of time when we're doing our C-sections, we have them ready to go on the table, the OR table, and even then, anesthesia will tilt that bed. It tilts very slight, not that they fall off or anything, and they're belted on anyway, but we never ever let them flat on their back. Never, never. Okay, it's called supine hypotensive syndrome. They get clammy, they diaphoretic, they feel sick, and it's again from that drastic drop in their blood pressure. The uterus, again, we talked about Braxton Hicks contractions, those annoying contractions that it's the tightening and relaxation of the uterus. Usually I call it practice contractions. It's not anything like labor unless you walk around, you exercise, you do something, and they're still there. That's probably real labor. That's how you distinguish Braxton Hicks from true labor. They're not true labor. Method used to assess the gestational age. Well, remember, we talked about the weeks gestation, right? So when she goes to clinic, she's going to go to clinic and they're going to measure her belly with a little paper tape measure, and they call this a fundal height because another name for the uterus is a fundus. Fundal height. So the fundal height is measured in centimeters, and usually, like 20 weeks, she'll be 20 centimeters. It correlates with their weeks gestation. I don't know how it does that, but it does. Until about 38 weeks gestation. What happens at the end? Does the baby drop and get ready in position in that birth canal? Yes, it does. It drops. The baby might be way up here, and then all of a sudden at the end, you ever heard Grandma so-and-so say, oh, that baby's coming. That baby's dropping in her vagina. Yep, it's coming. She dropped since the last time. Look, what baby's dropping down. So yes, the baby does drop down. Come on, come on. The baby will drop down. So it doesn't correlate from 38 weeks on, but it will correlate up till then. Here is a diagram. It's on page 172 of your text. You probably want to look that one over. because you might see something like that or similar to it. Just to let you know, at 20 weeks gestation, that fundal height should be at the umbilicus. As you can see, that's the diagram. Just to say where the fundus is in the abdomen. You need a chair. If you can't find one, come sit at the table up here, baby. Okay, the cervix. The cervix is something that I've kind of touched on when we talked about Chadwick's sign, the bluish color. It increases in vascularity. We call it competent if it can withstand the pregnancy. If it can't, and we have a patient that may have multiple losses, she's had multiple miscarriages because her cervix is incompetent. It can't withstand the pregnancy. Sometimes we have to put a little stitch or two in there called it's called a cerclage, which is something you might hear me talk about later. But anyway, it's to help hold the pregnancy. So it's competent if it holds the pregnancy. Talked about Chadwick's sign, increased vascularity. The mucus plug, there's a plug of mucus that kind of seals off that pregnancy, that vagina, all that area. Okay, the mucus plug is made mainly of, is it acidic or alkali? It's acidic. We're killing all those nasty germs and bugs and bacteria that can get up into that baby, right? Now, the amniotic fluid around the baby in the sac is alkali. But the mucus plug is something that seals off, and it actually looks like something that you would blow out of your nose. I have to tell you. I mean, I'm being pretty just blunt with you. There's nothing nice about it. But it can be lost weeks before the baby actually comes. It's not anything that the baby's going to fall out as soon as the mucus plug is in her panties. Okay? But it's a good indication that things are going along and things are kind of starting to move where we're going to be preparing for this baby sometime soon. The ovaries, they will stop producing ova during pregnancy. But those pregnancy hormones will go to 6th to the 8th week of the pregnancy. Progesterone is excreted or secreted until the 7th week of pregnancy. The vagina will thicken, become more pliable, more distensible, and there'll be an increase in secretions, again, acidic, right? But it thickens, it gets more pliable and distensible. It's got to withstand this pregnancy. There's a lot of pressure. But then it also has to be pliable to be able to form and get that baby through that birth canal and open and kind of move. The breast will increase in size, nodularity, sensitivity, again related to hormones. Nipples enlarge and darken. They prepare for lactation. And colostrum is the first breast milk that kind of comes out. They can leak prior to delivery as well. Some moms will leak. Again, it's related to hormones. And they may have to wear little breast pads in their bra just to kind of, I was telling the last class, I said I'll never forget it, but I was in Winn-Dixie or somewhere, and I was like 3 weeks before I had my son, and I had some like little discharge in my bra, so I was wearing the breast pads. Well, this baby starts crying in the line down that way, and it was like, just saturated my whole shirt, even though I had breast pads. It's called the letdown reflex. It's nature's way. The baby cries and the baby needs to be feed that baby, right? I guess. I don't know. But anyway, it is a reflex, and the breast milk just comes, okay? So the colostrum, people say, oh, that's nasty stuff. There's nothing hardly in there. Just take that and don't breastfeed the baby because it's just colostrum. Well, no, that is the stuff that you want the baby to get. It is the cream on top. Okay? It has so much in it to protect that baby. Studies are even showing now there's so much antibodies built up in that colostrum that can even protect them from cancers later in life. You know, it definitely gives them a boost of immunity. Okay, so it's very, very good. It's very important. It is a yellowish kind of very thick breast milk. And the patients will tell you, oh, it's just that colostrum. There's really, my milk did not come in. Because the breast milk will come in, like, I would say like 3 to 4 days after delivery. It should come in. And when it does, it's like rock hard. Your breasts get rock hard. But the colostrum will come out before then. And that's also very good for the baby. So don't discourage them. Cardiovascular wise, well, that growing uterus, because that baby is growing inside, it houses the baby, tends to rearrange the furniture inside, I call it. Displaces the heart upward, rotates it forward, moves the lungs out the way. That's why they have shortness of breath sometimes. They feel like they can't breathe. The baby's up into their lungs and their diaphragm. You'll have an increase in plasma volume, which leads to an increase in RBCs, which can lead to physiologic dilutional anemia. So what is that? Anybody? Well, you have a lot of volume, right? The plasma dilutes it. It's still there. It just doesn't seem like it. They seem to be anemic. But what it is I explained to the last class as well. When you mix a pitcher of lemonade and you add twice the water to the powder, it's very weak, right? Seems very weak, but it's still got the same amount of powder in there to mix it. It's just not as strong. So with this, there's more blood volume. Even though her blood count's normal, it just seems like there could be some anemia, but usually it's fine. Okay. Sometimes they call it pseudoanemia, but they do have an increase in RBCs, and they get that dilutional anemia because that increase of volume. They do have an increase in heart rate. Of course, when you increase the plasma volume, there is a slight increase. It's not abnormal. It's still normal, but it is slightly increased. Increase in cardiac output, increased tendency for coagulation. As far as the lungs, the respiratory, they'll have an increase in oxygen requirements. They have a decrease in vertical diameter, increase in anterior posterior diameter. They will complain of shortness of breath, increase in tidal volume. They do have an increase in vascularization of the upper respiratory tract. They always feel stopped up, kind of stuffy. They may even have nosebleeds. Remember, they have this surge of blood volume, okay? So everything feels engorged, kind of like when you're really not feeling good and you have a bad cold or a sinus infection. There's a lot, you just feel like you can't breathe. Again, it's related to that increase in blood volume. So, unfortunately, you can't take a whole lot for that, but we can take some things I'm going to talk about in just a second. Renal. They have a 50% increase in glomerular filtration rate. So they tend to have a decreased renal threshold for glucose, which means, what are they prone to? What's spilling over? So they have an increased risk for UTIs because they have a decrease in that smooth muscle tone. That glucose is just spilling over. It's a perfect medium for bacteria, and they get UTIs. Skin, the integumentary system changes. Striae gravidarum occur, and that's the lower picture. It's kind of a pitting of the skin. Kind of looks like somebody just kind of took a little pin and just kind of pricked the belly and made these little indentations. And they kind of could appear as silver lines as well. Anywhere the skin will stretch, it could be on the belly, could be on the breast, could be on the buttocks, could be on the thighs, could be anywhere. Anywhere the skin is stretched to make room for that growing baby, right? Unfortunately, that's the baby's little souvenir to mommy. They really don't go away. They have all these miracle creams. It's like cocoa butter. People will put the cocoa butter. It helps probably keep the skin moist, but it doesn't really take it away, and it does not really leave. There is some kind of laser procedures out there now. I know that they're, working on to help with that, but it is something that is pretty, permanent. On the other hand, the other picture is linea nigra. which is a black line that goes down the middle of the abdomen, that is related to hormones, usually the pregnancy hormones. So it should dissipate or disappear after the pregnancy is over. And usually it's like a few weeks after pregnancy, because believe it or not, you do have circulating pregnancy hormones still going until a few weeks after. Cloasma. Cloasma is the mask of pregnancy. It's kind of like a blotchy type rash, not rash like itchy rash, just kind of blotchy discoloration of the face. And we always recommend that they stay out of direct sunlight. So like if you go to the beach, stay under the umbrella, because the cloasma can get a little bit worse. These are just some things that can change. Vascular spider nevi, usually in the lower extremities, from having all that extra weight and walking, a lot of pressure in those extremities can cause some little, looks like little varicose veins, but they kind of real light and faint and very, very pale. But they can occur as well. Palmar erythema is a rash. It looks like a lacy type rash, kind of like blotchy on the hands. Again, this is temporary, doesn't really stick around. It's related to hormones. Not everyone has all of these things. I just want to let you know. So if you didn't get half of these things, consider yourself lucky. Not everybody gets this, but it's just things that can occur during pregnancy with the skin. Okay, musculoskeletal, they tend to be lordotic. They tend to lean back, right? Because the baby's growing, it's pulling them forward, and they're trying to keep their center of gravity balanced. So they tend to have a lot of lordosis. And because of that, they tend to get a lot of backache. They also get waddling gait because they feel like at some point it feels like the baby is pushing on your joints and your groin. It feels like it's like ready to fall out. Of course it's not, but you tend to waddle because you feel like something's there. So it's a really attractive gait that you have when you're pregnant, especially at the end. Rectus, diastasis rectus abdominis. This is those six-pack abs that go out the window once you're pregnant, right? Those two little muscles that are sewn nice and tight look awesome. Well, when you get pregnant, they go away. They actually split apart, and they will stay that way no matter what you do. You could do sit-ups till the cows come home. The only thing you can do is get those sewn back together with a tummy tuck, and they tuck those muscles under and make them nice and tight. Other than that, that's also a nice little souvenir you get left. There's an influence of relaxin. Relaxin is one of those hormones that actually can affect the growth of your feet. It's a joint, it relaxes the joints. So like with every pregnancy, I remember I grew a half an inch in my shoe size. So I started out with a 5.5, and then I went to a 6 with my first child, and then a 6.5 with my second child. And I said, that's it, I'm done. Done cleaning out my closet. All of those shoes going to Goodwill because they don't fit you anymore, thanks to relaxin. And then those round ligament pains, the round ligaments of the uterus, because the uterus is a big muscle. Well, as the baby grows, it pulls on those round ligaments, and it tends to feel like they have this bad groin pressure or pains in their groin. Carpal tunnel syndrome, they have that extra volume, so there's a lot of pressure compressing those nerves in that hand area, the wrists. So they do tend to get carpal tunnel, which again could go away, but this one actually, I've known a couple of patients that said their carpal tunnel kind of stuck around. So some things can stick around, and some things will cease. GI, there's displacement of the stomach, the intestines by the uterus. Things shift, move around. Things slow down. So there's a decreased production of HCl and pepsin, which help with digestion. So they get indigestion because there's decreased production. They have an increase in saliva production called ptyalism. They tend to have a lot of saliva. And they can get pica. Pica is a craving of some sort that's not nutritional value to the mom. And like I was telling the other class, when I lived in the Midwest, I worked in a hospital that was near an Indian reservation. We had a little Indian lady that would come in, and she was high risk, so she was coming in for some procedures and stuff. She'd bring a little piece of foil with her red clay, and she'd eat it. And I would be like, wow, that's not good for her. And I just couldn't deal with it. I was like, you just shouldn't be eating that, ma'am. Why don't you eat a banana after that? That would make me feel 100% better. So it's something of no nutritional value, but they crave it, like ice, starch. Yeah, I had a lady that used to eat starch out the box when I worked at big charity. And it was just one of those things that they craved. And if you told them they couldn't have it, they might do it for you there, but they're going to go home and eat a whole box of starch. So it's just something that, they crave. But you don't have to be pregnant to have a pica. You could be we get patients that come in sometimes and they want that crushed ice out of the machine at the hospital. That's their pica. Nothing of nutritional value, but they crave it. They do have an increase in gallstones, so the sludge does increase. It's not unlikely that a patient is having a cholecystectomy in the middle of the pregnancy. It just happens, and that's because they're at risk for gallstones. They do get morning sickness, but it could be afternoon sickness, it could be night sickness, it could be any time. It doesn't necessarily mean it has to be in the morning, but patients do tend to get that nausea and vomiting. Usually it's the first trimester, but not limited to the first trimester. Some people have it all the pregnancy. And again, it's related to HCG. There's an increase in human chorionic gonadotropin, which is the pregnancy hormone. It's very, very, very high in the blood at the beginning. So they're more prone at the beginning. They get hemorrhoids. That growing uterus puts a lot of pressure on their rectal area and causes hemorrhoids. Another one of those wonderful things of pregnancy, right? Endocrine, estrogen's increased. Progesterone will stop after the 7th week. So these hormones, HCG, we just talked about that. That's the pregnancy hormone. And actually, HCG is what turns the urine pregnancy test positive. It's sensitive to HCG. It picks it up in the urine. It's also measured in the blood. Prolactin is another hormone, deals with the breasts. Relaxin, those feet will grow, relaxes those joints. And oxytocin is a natural hormone that is the labor hormone, I call it. It makes the uterus contract. It's released normally in the body. It's very, very much so related to nipple stimulation. So we tell moms that are tired of being pregnant after 38 weeks, of course, like 38 weeks on. If you have nipple stimulation and you have sex, maybe you'll come in and have that baby, right? Because it causes that uterus to contract. We also have a synthetic one in the hospital. It's called Pitocin, but it's oxytocin. It's a synthetic man-made IV. Nutritional aspects. Weight gain. Well, it's not all baby, y'all. They don't have all baby. It's actually the breast, the uterus, the fetus, placenta, the amniotic fluid around the baby, and the sac. That all makes up the weight gain, okay? Usually 25 pounds is the average weight gain. We really don't want them gaining a whole lot. There's no 25-pound baby inside. I have seen a 10-pound baby inside, and I've seen bigger babies, but it's definitely not going to be. Now, twins, they'll gain more, but there's 2 babies inside. So 40 pounds is not unlikely for a mom with twins. But they do they gain weight. Majority of the weight is gained in the last trimester, by the way. Physiologic adaptations, nutritional aspects, nutritional needs. I will tell you this. Folic acid is so important. That and prenatal vitamins should be taken even when you contemplate the thought of getting pregnant. It cuts down on the neural tube defects, the folic acid. Studies have shown that spina bifida and neural tube defects have been decreased because of folic acid. So we definitely want to stress that to our patients. Nutritional risk factors, well, those teen moms are at risk for nutritional problems because, of course, they're all into their body image. They don't want to gain weight. It's not a good time to diet. We do want you to eat healthy, but again, there's lots of teaching, lots of patient teaching. Also, you might have a patient that wants to eat healthy, and she's like, I have limited money. Because all those things out there that are cheap are carbohydrates, right? You can get carbs really cheap. It's the meat and the veggies and the fruits and all the good stuff that costs the most. So we talk to them and get them hooked up with WIC or some kind of assistance that they can get help to eat very well and keep nutritionally, stable. And also it can help with them getting on WIC for the baby after. And did you know that WIC will rent, it's free breast pumps? So there's no reason why mom can't breastfeed. Because they used to say, oh, the formula's free. I mean, the breastfeeding thing, it's just too hard. And, when I want to go out and stuff like that. Well, now we have breast pumps available. And they can get breast pumps. So there's no reason. The breast milk is the best thing. So, okay. Physiologic discomforts and interventions. First trimester, nausea and vomiting. What can we do? Well, they get that morning sickness. We have soda crackers, Sprite, ginger ale. Ginger, by the way, is an herb that is really good for your stomach. And actually, I didn't tell the other class, but they'll hear it on the recording. But ginger was a question asked on state board. Somebody came back and told me, Miss Herrera, when you told us that ginger was good for morning sickness, do you know that that was on state board? So you might see it again. But it helps with nausea and vomiting. So ginger ale, anything like that. Or, before they get out of bed, because sometimes right when they lift their head off the pillow, they feel sick. Urinary frequency, well, go when you have to go. Do not hold it, because you can get yourself a good UTI. Remember, they have an increased susceptibility to get UTI, so you don't want them to hold their bladder. That's that growing baby just bouncing on that bladder. So let them make sure they go. Breast tenderness, a good supportive bra. Increase in vaginal discharge. Cotton panties also helps with the UTIs, but it also helps with that. Panty liners are okay to use. Nasal stuffiness and epistaxis, like an ocean spray. And they can get nosebleeds because, again, all that increased vascularization. So keeping that nasal passage kind of lubricated kind of helps with that. Botulism, hard candies, gum, something for that excessive salivation. They usually carry that kind of stuff in their purse just to kind of have something to have. Fatigue, well, take a power nap. Take a nap. You go home from work, you're tired, you need to lay down. I mean, your body's telling you need to rest. So just make time for that too. Pyrosis, constipation, all these things, of course. Constipation, we probably could take a stool softener, but really my first thing I'd want to do is to change my diet. Drink plenty water, plenty fluid, and of course eat high fiber. Things you want to do for these ailments, think non-pharmacological first. Hemorrhoids, witch hazel. Witch hazel's natural, it's in the bottle, or you can get the Tux pads. Those you can do over the counter. Sitz baths, those kind of things. Ankle edema, from swelling, from being on their feet all day. Sometimes that ankle edema is just something that is just, it's going to happen, especially by the end of the day at night. So we tell them to elevate their legs, put them up. Varicose veins, supportive hose of some sort if they need to. Leg cramps, same thing, those supportive hose. Backache, pregnancy girdle, where there's a band that kind of holds the belly up from under. It's not anything that's going to compress the stomach. It's a band that goes under the pregnant belly. Helps support that belly to ease up on that back, because that's where all that back pain comes from. And the round ligament pain, that should help with that as well, because it supports that heavy uterus from pushing down on those round ligaments. Braxton Hicks, well, we can't make them go away. If they really are Braxton Hicks, though, once you start walking, exercising, they should cease. It should stop. If not, you're in labor. Insomnia, lots of pillows, back rubs, warm milk at night. If your doctor lets you have one caffeinated product a day, like a cup of coffee or a Coke, usually drink that toward the beginning of the day, because if you do it later on, like after 1 o'clock in the afternoon, sometimes it can keep you up. So, plus you're just so big and uncomfortable, it's hard to get comfortable and sleep. So lots of body pillows. Headaches, make sure you eat small, frequent meals. You know, because sometimes it's your blood sugar that drops that gives you the headaches. Mood changes, well, everybody's moody when they're pregnant, but, you know, they cry easily. They're very emotional. It's all good. It gets better. It goes away. It's temporary. Faintness and dizziness, they too tend to get that. They're always hot. Okay, because when I lived in Midwest, we had a lot of snow. I had 2 feet of snow on the ground, and I was out with shorts and a T-shirt running around. My husband was all bundled up with a hat and gloves. He's like, okay, what's wrong here with this picture? But again, it's, you know, so you get them in a very, very, very stuffy room where there's not enough air circulating, they can pass out on you and faint. Dyspnea, difficulty breathing, just again, you know, you want them to kind of wear clothing that it doesn't compress that area, their diaphragm. You want them to be comfortable. Altered body image, yeah, you're going to be fat, you're going to grow, your body's going to look disfigured, but you're pregnant. It's all normal, and it should go back to normal, hopefully. And if it doesn't, well, you got to do some exercising and maybe get a tummy tuck. Pica. Pica is, again, that abnormal craving, but follow it up with something nutritional. Carpal tunnel, you can wear the braces on their wrists. Nothing pharmaceutical, but again, just those braces. This is what you can do. Put your legs up by the end of the day. If you can't put them up on a recliner or pillows, you can do it on the wall. And these little, that's just some posture exercises they can do with their posture for backache. Lots of body pillows, back rubs. And these are some exercises. They're kind of like a flex of the foot toward the knee. And then the little lounges. Anything that stretches that back muscle, that gastrocnemius muscle in the back, because that's usually where the cramping can occur as well. One more thing I didn't cover that you might want to think about. How can you tell the due date? The last menstrual cycle, the first day, subtract 3 months and add 7 days. So you might see, it's called Nagel's rule. You might see on the forms that you fill out at the hospital, EDC, estimated date of confinement, is a fancy name for the due date. EDD, estimated due date. But it is Nagel's rule that helps you figure that out. So if your patient told you her last cycle was June 10th, when would her due date be? How you figure it? March 17th. So the first day of her cycle was June 10th. So you're going to subtract 3 months and add 7 days, right? So you have a St. Patty's Day baby, right? Okay. Any questions? Miss Shemake, you have something to say?